Hello, good evening, and welcome to this EAO Just Ask, your monthly live appointment with a leading expert in implant dentistry. My name is Gerrit Heikoop, and I'm the host of this EAO channel. And tonight, in this special edition of our live video session, we are going to try to answer as many questions as we can about two topics of the EAO Consensus Conference 2021. And therefore, I'm joined by two remarkable experts. Joining us live from the UK is the chair of the first working group, Professor Nikos Donos, to discuss with us the consensus on the impact of timing of dental implant placements and loading. Good evening, Nikos.
Good evening. Hello from London. Nice to be here.
Glad to have you with us. And also joining us live all the way up north in Tromsø, Norway, under the polar lights, is the chair of the fourth working group, Professor Asbjorn Jokstad, to zoom in on the consensus about the merits and unknowns of digital tools in prosthodontics. Good evening, Asbjorn.
Good evening, Gerrit. Thank you for being here.
Yeah, we're very glad you're here, and we're also glad that you here, dear viewer. As always, I'd like you to check in and let us know who you are and where you're joining us from. I already see Ayusha Fauza checking in from London, a student from Nikos, we learned. Bjorn Klinge, also a co-chair of the Consensus Conference, is joining in from Sweden. And also Per Otterstad is joining from Norway as well. If you're now just joining us, let me know in the live chat who you are, because the way this hour will unfold is that soon, for the first half hour, I'll check in separately with Nikos and Asbjorn about the most remarkable findings and, more importantly, the clinical implications of the work that has been done by these two groups in the Consensus Conference. And then in the second half, I'll try to address as many of your questions to these both experts. Now, before we start, let me provide you some context of what the EAO Consensus Conference actually is. Because every 3 years, the EAO organizes this Consensus Conference to discuss the topics which are of great importance to our profession. Now, and the outcome, this high quality academic work, then serves as a reference point for academics and clinicians around the world. And in this 2021 edition, it was a 100% online endeavor, which was chaired by Irina Saylor, Henning Sliephake, and Bjorn Klinge. He already noticed himself in the chat. And they were joined by over 70 experts from around the world to address more than 20 questions on 5 very specific topics. Topic number 1, timing, which we are discussing with Nikos today. Topic number 2, soft tissue management, and 3 was peri-implantitis, which we are discussing in our next EAO Just Ask, which will be on January 17th. Topic number 4 was the fabrication, workflow and delivery of the construction, which we are discussing with Asbjorn tonight. And 5 was a special topic on COVID-19 and the European recommendations and experts' opinion on that. Now, the good news is the Consensus Conference report or publication is currently available on the EAO website, and right below this YouTube video, you find a direct link. So make sure you download it, check it out, and make use of all the hard work. In the meantime, we see a lot more audience members checking in. Mario is joining us from Brazil. We have Franz Joseph Strauss from Zurich in Switzerland. Ioannidis Pascalidis is ready for the session. Denmark, Lisbon, Spain, Tel Aviv represented. Truly a global audience. So let's get started right away. Nikos, I'm going to start with you and your topic. Now, besides the chair of the first group doing work on timing, you're also a director of research and a professor of periodontology and implant dentistry at the Queen Mary University of London, and then specifically the dental school there. And more importantly, you have been involved in at least the last 5 consensus conferences of the EAO. So very interesting to learn from you. What are some of the key take-home messages that you take from the consensus report that your group has worked on?
Thank you very much, Gerrit. It's, of course, a great pleasure to be here today, and thank you to the EAO for providing me the opportunity to comment on the deliberations that we have had within our Group 1. I cannot just say that it's on 1 or 2. I think I will need to take each systematic review and discuss each systematic review and provide the clinical recommendations that could come up from the discussions and the synopsis that we have had as a group. I must admit, and I must say that the topic was very interesting, very exciting. It's very clinically relevant today. It has been for many years, but more and more research has been appearing to be happening in the different centers around the world. So we were all anticipating to have a lot of evidence to provide very important clinical tips to our audience. I must say as well that the work was the panel worked very, very hard. The group worked very, very hard, and I have to congratulate the authors of each individual systematic review for the fantastic work they have done, but also the panel members for really working very hard under the really good organization of the EAO for this consensus, which was all remote, and of course that had its challenges, but also it was a very interesting way and productive way of working. So the first group was all about timing of implant loading, timing of implant placement, loading, and the combinations. And the first systematic review was dealing with the question. The objective was to investigate the impact of timing of implant placement and loading on the implant survival and the biological outcomes of multiple unit implant-supported fixed dental prosthesis. We're going to call them from time to time FDPs from now on. But before we go to the specific clinical recommendation, I think there's some particular components in this group one that they need to be emphasized for our audience to be able to follow how things were evaluated. And here we need to have some definitions, which they were more or less universal, but there were some differences between systematic reviews in terms of what is implant placement, the timing of implant placement, the timing of implant loading. So in terms of implant placement, we have the immediate implant placement, which is basically placing the implants on the same day of the tooth extraction. We have the early implant placement, which are implants are placed when some soft tissue healing already took place and some partial bone healing took place. And in the first systematic review, that was between 4 and 8 weeks or 12 to 16 weeks after tooth extraction. Now, this is important in terms of our future discussion today and maybe later on, because this, of course, represents the two large periods where healing already has taken place, and this may affect what we evaluate as data. And the late implant placement is, well, the implant placement when the healing has been completed, and this is usually more than 6 months after the tooth extraction. Then we have the implant loading components, where we have the immediate implant loading, where implants are connected to prosthesis within 1 week subsequent to implant placement. We have the early implant loading, which is implants connected to the prosthesis between 1 week and 2 months after implant placement. Again, a very wide period which clinically may or may not have an impact. And of course, the conventional loading, which is more or less all of us we are familiar with, which is basically implants allowed to healing for a period more than 2 months after implant placement without any type of connection. And I think here in this first systematic review, what it was really interesting for me to see was that there were no specific differences in survival rates between and marginal bone losses between delayed placement and delayed loading, and delayed placement and implant loading. These are the two groups that we could come with some specific robust clinical recommendation, saying basically that following delayed implant placement, the timing of implant loading does not influence the survival of implants supporting multiple unit fixed dental prosthesis. And this is an important outcome that comes from this first systematic review. But here, again, from the research component, what the panel was really putting emphasis was the heterogeneity and the quality of the data that did not always allow us to provide robust data.
Mm-hmm.
The second.
So, Nikos, I hear you say there's almost a kind of a big table of where we look at implant placement in 3 timings, loading in 3 timings. And when you say when we're at least in the row of delayed placement, there was no significant effect on loading, right?
So following delayed implant placement, that's correct. The timing was not, if you place it delayed or immediate, it did not indicate any difference in terms of implant survival. Yes, this is a clear clinical recommendation that we came up with. If we now move to the timing again in terms of how the timing of implant placement and implant loading would influence the aesthetic outcomes, that was a topic that was very clearly covered by the systematic review by Helena Francisco. And again here, just to make things slightly more complicated, the timing of implant placement was, again, immediate implant placement, which was on the day of the extraction, fair enough. Early implant placement, which was from 10 days to 8 weeks after tooth extraction, again, some variation. And of course, we had a delayed implant placement, which was from 3 to 6 months, whether the previous one was from 2 months onward. So I think this is also an important point to keep an eye in consideration when we evaluate the data. Now here, again, we talk about aesthetics and then the number of indices that they're used in these papers. And this is the indices, which is the pink aesthetic score, the white aesthetic score, and the papilla index score, which has been predominantly utilized to evaluate the aesthetic outcomes, as well as the mid-facial recession that was before or after the different procedures. These were the main outcomes that they were evaluated in the systematic review. And again, here, if we look at the different clinical recommendation, it was interesting to say that amongst the most important clinical recommendation was actually you need to register your measurements, your clinical measurements, from fixed and reproducible landmarks. And this indicates the variety that we have in the literature, and sometimes that what we compare is apples with oranges when we compare the different studies, and we need to be very careful how we interpret the different measurements because the landmarks are not always the same. I think a very clear message, clinical recommendation, is that the clinician may use immediate loading or actually creating a provisional temporary crown immediately in single implants without compromising the aesthetic outcome in the medium term. I think this is one of the most important parts that they came up in this publication. If we move now to the third review, was about the medium to long-term outcomes of the timing concepts, both placement and loading, but focused in the anterior maxillary region. And here the authors really defined the area that they wanted to see these changes. It was between the canines, and the discussion here was that we want to see changes over 3 years. And second is that we take that the premolars heal differently than an anterior, than an incisor, and as such, we only evaluate this specific area. Here, the authors evaluated a number of papers and a number of type of systematic reviews and the pooled data, a number of clinical trials and the pooled data from different clinical trials. And really the consensus statement and the clinical recommendation are not really far from each other. So here we say actually a very broad term consensus statement that there is evidence, there's clinical research evidence that the different timings for implant placement or loading that they were evaluated in this review are actually associated with high implant survival rates for up to 10 years of follow-up. That's a consensus statement, which is very close to the clinical recommendation. And of course, we can have some discussion about it because it's a very generic statement. The fourth review was by the Danish group.
Just on the third, I'm processing what you just said. You said the consensus is that there is a relation. Is there anything said about the direction of the relation, or is a relation that late timing or delayed is better, or doesn't it say anything about that?
No, what we say in terms of a clinical recommendation is that the different timings of implant placement and implant loading, they are having high survival implant data, and that's it. It doesn't say that one procedure is better than the other. It doesn't say that if you combine something, it will be much better than something else. Okay. But in this systematic review, we're talking about a very strict area. We talk about data maybe that it was not always of the highest quality. And as such, I think the panel decided to give this more or less general recommendation, which, of course, it can be interpreted in many ways. I think here it is important that the clinician's judgment, as always, the clinician's judgment is massively important. But here in this situation, the clinician's judgment and all the knowledge of planning, anatomy, and all the landmarks that they are around in the area, and of course the tissues that are in the area that we operate are important before we make a decision for which kind of protocol we're going to be following.
Yeah.
The fourth systematic review was a very interesting systematic review because it moves away from the dentist. It moves away from what we want to do to our patients and finally asks, what do the patient want from the treatments that we're offering them? And this becomes very relevant. And I was actually very interested in the outcomes of the systematic review personally, because we as dentists always want to do things fast. We want to place implants fast, we want to restore fast, and we are convinced that this is what our patients want. So in this systematic review by Klaus Gottfredsen, the focused question is, what is the patient's perception for immediate early placement or immediate and early implant loading in comparison to the traditional conventional placement and loading? And they evaluated they evaluated cohorts of patients that were partially edentulous patients and they were the edentulous patients. Now, for the partially edentulous patients, here we had an outcome, a consensus statement that, deriving from the systematic review, that the hypothesis that patients would prefer immediate implant placement and loading, actually from this systematic review, could not be strongly supported by the literature that we have. There were studies that indicated that this might be the case, but also there were the studies that were neutralizing that. So that was a very interesting part that, you know, maybe things are not always what we think they are. When we look at edentulous patients, again, there was some evidence that when we look at implant-supported full arch fixed dental prosthesis, for implants for full arch, then in these situations, there is some evidence that patients are more satisfied with immediate than early and delayed implant loading. But again, the time of assessment could influence the outcome. When we looked at implant-supported, when they looked at implant-supported overdentures, again, here we have the third group, the results were inconsistent, but overall, there was a high overall patient satisfaction with implant-supported overdentures in the lower jaw. So inconsistent results in terms of the implant timing and implant placement. So here the consensus statements, if we separate it in these three areas, was that, yes, there's not strong evidence that the timing of implant placement or loading of implant-supported single crowns or partial dentures influences the patient's comfort or satisfaction, which it was interesting to see. There is some evidence that patients for full arch prosthesis demonstrate higher patient satisfaction when we have immediate rather than early or delayed implant reconstructions, but this is for the first 3 months period. As the timing is moving ahead, that after a year, actually these differences disappear. And I think this was a very important statement as well. So whatever we do to these patients is probably on the short term. There is an important part here that the authors discussed quite a lot in the discussion section, and it came also for the future of research. Prompts are, in some RCTs in the included review, were the primary outcome. But actually, one of the future recommendations is actually we need to have prompts as primary outcome variable, because very often these studies may have not been powered for prompts. And as such, all these differences that we have been discussing may not be actually valid. And the other point is that the sensitivity of the tools that we use for the prompts may or may not always be appropriate for evaluating patient-reported outcomes in relation to implant timing and placement and loading. And again, a larger discussion, but really created a lot of good brainstorming for the future studies. So I think overall,
Wow.
this group dealt with what the dentists want, what the different protocols are in the anterior and in the partial edentulous patients, but also what the patients want. And I think the point here is that we know some things, but we know that we do not know a lot, and more robust evidence is needed at these specific areas as they were delineated in these reviews. A final comment here is that we as clinicians should not get disappointed that we do not come with 3 or 4 or 10 clinical recommendations. One recommendation is enough when this is the strength of the evidence that we have. And then we build up for the next consensus conferences. So I hope I created, this is the points that really come out as most important in my view from our panel.
Yes, and Nikos, this is very impressive. You used exactly 15 minutes to talk us through the highlights of the work of your group. It went fast, it went high over. I must admit, I had the 4 different review articles, at least the titles in front of me as well. So if you are just joining us, be aware that below the YouTube video where you're watching right now, you can also click on the link and get into the consensus report publication and read along and use it for future reference after this hour as well. Thank you so much, Nikos Donos. If you have been listening to the last 15 minutes and you have a question on any of the 4 different review articles that Nikos talked about, please submit your questions in the live chat right now. I will store it right here, and in the second half of our hour together, we will then try to answer as many of your questions as we can on the topic of timing on implant and dental placement. Now, if you're just joining us, we have 2 topics to cover here tonight, and we're now switching from the UK back over to Tromsø, Norway, where Professor Asbjørn Jokstad is joining us. Asbjørn, good evening.
Good evening, everyone.
Yes, good to see you again. Yeah, besides the chair of Group 4 that worked on fabrication workflow and the delivery of the construction, you're also a professor at the Institute of Clinical Dentistry, specifically at the Faculty of Health Sciences at the Arctic University of Norway in Tromsø. You're an emeritus professor of the Universities of Toronto and Oslo, but more importantly, you were one of the inaugural editors of Evidence-Based Dentistry. So also a great person to have with us tonight to talk us through the consensus on the work of the digital tools in implant prosthodontics. So same question to you, Asbjørn. What are some of the key remarkable take-home messages and findings that you would like to share to kick off with?
Well, thank you very much, Jared, and thank you for being allowed to elaborate a little bit about what I think is a really fascinating theme. And that is, what should we replace with computer-assisted services, and where should we continue to use our brain, eye, and hand coordination? Because there's so much going on within this field now that we lose track occasionally. And basically, the fabrication workflow and delivery, you have both worlds, and we want to pick the best from both worlds. Work grouping 4 consisted of a consensus paper based on 4 systematic reviews. The first one was on the complication rates, failures, and the survival of monolithic all-ceramic implant-supported single crowns. Very importantly, systematic reviews have to be or should be reported according to what is called preferred reporting items for systematic reviews and meta-analysis, so-called PRISMA. So for those of you out there, if you want to read systematic reviews, if it doesn't state PRISMA in the first section, go and read the next paper, because today that's sort of the standard. First, I'm going to spend 15 minutes. First, just a little bit about the 4 different themes, and then a little bit about consensus paper, how that works, and then the clinical most relevant suggestions for you clinicians out there. First group here, joint Swiss, Iceland, Russia, and Germany. The PRISMA format is that you have to describe how to study, how to select the studies, how these characterize, if there is a risk of bias, that is, if we should believe these results or not, the results of the studies and the synthesis, and then to what extent do we think this evidence is good. And this sort of PRISMA format follows all the 4 different systematic reviews. The next one was by a group in Zurich, which compared the production time, effectiveness, and cost of different types of computer-aided manufacturing of implant prosthesis. And when we're talking about computer-aided manufacturing, we have additive methods, which easiest to explain, say, okay, 3D printers, and subtractive, which easiest to understand is milling. And then you have all kinds of variations. The third one was about the time and cost related to computer assisted versus, and in lack of better word, non-computer assisted implant planning and surgery, KIPES, which was also a German group together with Daniel Wismeier from ACTA in Amsterdam, a very competent group on this. And then the last one, which was about patient-reported outcome measures. Do our patients really appreciate that we are switching conventional approaches with all these computer-assisted approaches? And this was a pure group from Aachen in Germany, led by Stefan Wohlfahrt. Now, the task of a consensus committee is really to then digest what are the major findings in these systematic reviews. How should we interpret the findings, the data? Because one thing is the data, another thing is, well, do we really trust these data or not? And then based on that, we want to come out with recommendations for clinicians, and we want to come out with recommendations for researchers. The consensus report in work group 4 was a very international group from, Belgium, Germany, Iceland, Italy, Norway, Serbia, Switzerland, and the Netherlands. And everything was online and everyone was smiling all the time. So it must have been a fun activity. Well, not really. It was very, very, very strenuous to discuss sometimes statistical issues that arose. But I'm not going to bore you listeners to that. So what were the main conclusions? Well, the main conclusions in the paper on monolithic all ceramic implant supported crown is that both monolithic and veneered all ceramic crowns work well on implant supported single crowns. They can be recommended. But monolithic with minimal application of aesthetic veneering or without any in non-functional areas may be preferred to the veneered ones because it has less risk of superficial ceramic chipping. There is this one project, Lava Ultimate, which is now pulled from the market, which unfortunately showed up with very horrible results because of the cement film didn't work, so the crowns just degraded. And then very importantly, the users, the end users, they need thorough knowledge and the precise application of recommended adhesive cementation protocols, both if you do it extraorally or intraorally, because that's crucial really for the outcome of all ceramic implant supported crowns. And I can add that really it's a very, very complex world right now with abutments that you have bonding to by different types of ceramics. You have conventional copings that are cemented crowns on top and bonded crown on top, aesthetic veneering, aesthetic ceramics, hardcore ceramics. And it's a quite confusing world right now. And we have to remember that what is being published is actually what was planned 4 or 5 years ago when you wrote the protocol, solicited the patient, did your work, collected the data, submitted this for publication. And once it gets published, there's all kinds of new products out there. So that's always the challenge in interpreting these data. Second group, the production.
So,
sorry.
Asbjørn, you're basically saying we should always keep in mind that we're kind of looking into the past when we look at the scientific work.
Well, let's put it, another way of framing this is if I go to a shop now, I can buy iPad generation 8 and 9, and perhaps even 7. And, you know, what's the difference really? Because the technology is moving so fast ahead, there's always this, and we can't really wait. Well, we can, but you want to make use of the newest technology because you want this to the betterment of the patient care. But yeah, there are the best we have is basically scientific evidence, and that's what we're stuck with.
Exactly.
Computer-assisted manufacturing, that is how these prostheses are made by different types of machines. Quite perhaps surprising is that outsourcing to subtractive CAM is advised. That is, send your digital impressions or impression to milling centers. They give more precise results on basis of what we have science right now. For the use of additive CAM, that is 3D printing, there's no clinical recommendations can be provided because there's no scientific evidence. That is up till now 2021. Of course, there are projects out there that are being using this now where they 3D print zirconia, for example. So that will be perhaps next EAO conference. And then the less manual post-manufacturing that is expected, the better CAM procedures are suitable for the manufacturing of reconstructions. Nobody wants to spend time sitting with a patient next and adjusting things that arrive from these milling centers. So that's a sort of wasteful use of everyone's time. The third paper, the time and cost related to computer-assisted versus non-computer assisted implant planning and surgery, and perhaps surprising to many people, the diagnostics and planning when following KIPES are higher than in non-KIPES concerning cost and time. Maybe you should add that there were very few papers out there. There were 4 RCTs basically. And you can turn that around and say, well, it's the manufacturer's role to persuade the end users that this actually benefits the end users. So, I mean, the onus is on the manufacturer to support, to fund this type of study. Because operating costs are the driving economic factor in implant dentistry practice, material costs, which include hardware and software, and the time involved with different procedure steps needs to be considered. Third recommendation, clinicians should consider the additional time and cost against the expected improvement in the precision of position when placing multiple implants. And then KIPES cost that ties in with the previous one become less per implant the more implants are simultaneously placed, and the cost and time involved with the workflow becomes less per occlusion unit. Fourth paper on patient-reported outcome measures of implant-supported reconstruction using digital workflows. Optical impressions are recommended for implant-supported single crowns and short-span bridges to increase the patient's comfort. Irrespective of the type of impression, clinicians need to ensure that the associated laboratory manufacturing workflow leads to clinically acceptable accuracy, function, aesthetics, and long-term stability of the implant-supported restoration. In other words, it's not whether or not you do a digital impression, it's whether you have full control of the rest of the manufacturing process when it comes to the end results. And then the last recommendation was based on prompts. No recommendations can be formulated concerning the final implant-supported restoration resulting from conventional or different digital workflows. So it's not like there's evidence that it doesn't work. It's more like there is no evidence really to provide any strong guidance one way or another. So this sort of sums up the 4 work group main conclusions. There are other conclusions also that goes to, well, recommendations for conducting new research, etc. But that may perhaps be answered if there are any questions from the audience out there. So back to you, Gerrit.
Yes, exactly. Thank you very much, Asbjørn, for this very fast and very quick overview of all the hard work that was done in Group 4. Interesting dynamics of looking at the operational cost, the cost effectiveness, insourcing, outsourcing, almost a very business-driven research work that has been done. Let me invite back to our virtual stage also Nikos Donos and see if we can kind of now in the second half of this EAO Just Ask actually trigger our audience to submit some questions. And I can imagine if you're just joining us, and by now, Asbjørn and Nikos, we literally have connected a crowd from all over the world, from New Zealand to Venezuela, through Vienna, Germany, Saudi Arabia, Istanbul, Dubai. Literally people from all over the world are connecting. But I'm now also inviting these folks to then think about, okay, what have I just heard? What does it mean to my work in either my clinic or in my research? I bet you found it very fast. It was very high over. So where do we want to go deep? Let me know. Drop your question in the live chat and I will relay that to our experts on your behalf. One thing that I wrote down when listening to you, Asbjørn, just now, is that there seems to be a relation between the work on the second and the third paper, where you looked at insourcing, outsourcing, and the insight that one of the worst things you can have is adjusting things on the bedside versus the operational and the costing of digital workflows.
Well, the second part, the one on computer assisted manufacturing, is very particular to how you manufacture the actual prosthesis or all kinds of different types of devices. But you have different types of additive machinery, subtractive machinery, and it goes all the way down to Mickey Mouse milling machines that you can buy for a few thousand Swiss francs or dollars if you prefer, all the way up to really monsters that they use in milling centers. And because of these huge monsters that are being used on an industrial scale, what they are able to produce in terms of fits and material machining properties afterwards, because when things go very fast, there's all kinds of correction algorithms that have to be used in software. And this is taken care of in these industrial milling centers. While if you have your own small milling machine, it's fun, it's fast, you can do temporary restorations, but there aren't any data suggesting that you get the same precision. And precision is like alpha omega, to use a Greek word to wake Nikos up, for everyone.
Exactly. So it's all about speed. Talking about speed, this is interesting. Irina Saylor, one of the co-chairs of this year's Consensus Conference, is live with us in the chat. And she does a great suggestion to see if we can kind of connect these two topics together to both of you. She writes, do you see an influence of the technological possibilities on the increase of immediacy in implant dentistry? So meaning that the digital workflows may be associated with easier immediate implant placement and restorations. Is that the case, she wonders? Can you, based on the work you both did, kind of come to a consensus here live on air? What's your first thought, Nikos?
I would have thought that this is probably more towards us. It's not I want to pass the ball, but it's more on the group 4 than group 1. But of course, I have my thoughts, but I think it's more related to the work that Asbjørn did.
Yes, it's definitely correct what Irene Saylor pointed out. In California a few years ago, there was this concept, I think it was trademarked, teeth in an hour. The patient walked in, had their teeth removed, and walked out again with a new bridge. The possibility to do that was based on a fully digitized workflow where it started with the planning. You merge the so-called CBCTs with the layout of the final restoration. You had it milled out, more or less precise prosthesis, and then that was sort of retrofit afterwards. Now, of course, there's you need a very, very high level of expertise. So many others have settled for not teeth in an hour, but teeth in a day. That's still pretty fast. Where the patient comes in and there may be an element of including a conventional dental technician, or that can also be milled. But the whole idea of merging now beforehand all kinds of tomographies, and we're not only talking about radiology, we're also talking about all kinds of 3D facial technologies that are being merged. Even artificial temporomandibular joint movement, you can also figure out and plan in advance. So yes, the whole field is moving towards integrating all this with the final end product to provide the patient with computer-assisted solutions at their convenience. But it's not only about speed, it's also about the precision. And I shouldn't mention the name of one particular big company, but they went almost bankrupt 10 years ago when they promoted this live on stage and showed to the whole world that actually the project failed miserably in terms of precision. So it's been around for a while.
And if I may add here, I think what Irina mentioned is, of course, very important. And I think we can see that it will help us be more precise, potentially well better trained, more precise in our surgical approaches. And as surgical approaches also are modified and get potentially less invasive, we can use the digital workflow to become more good in our surgical procedures and evaluation of where the implants and how many implants can be placed and of course loaded. So I think this is definitely something that will be here for the years to come.
Yeah, and the reason I tied it into you, Nikos, is because I'm thinking you and your group has looked so much at different timings of the different cases. Did you see a trend, as Asbjørn describes, it now becomes possible? Do we now see a push for more immediate, or do you see no such relation at all?
Well, we see a lot of push from the profession towards immediate. That does not necessarily mean that we see push from the literature towards it. I think it was very interesting to see from the paper from Michael Peyer from Austria that basically the clinical recommendation is that following delayed implant placement, the timing of implant loading does not influence the survival. So we still got that if you place a delayed implant place, if your placement is delayed, meaning in robust bone, where potentially it's easier also to plan it and be more precise, then what type of loading, how fast you're going to load doesn't make a difference. Safe approach, safe surgical approach, which now allows you to push slightly the envelope for restoring the patient earlier. And I think this is actually a clear message from the literature. Again, if we look at how fast things can move in terms of aesthetics, it is interesting to see Francisco's systematic reviews that actually indicate that the different loading protocols do not make a tremendous difference. But of course, you can interpret that in many ways. That does not mean you should compromise on your surgical technique. And certainly, and that is emphasized throughout the whole consensus, clinical judgment, evaluating of all the anatomical characteristics, the type of the tissues, the area, plays a significant role on the final success, which is survival of implants. Don't forget that we evaluated survival of implants, meaning the implant is still there after a few years, and of course, marginal bone loss as well, which was not significant between the different loading protocols.
And just to double check, Nikos, I hear you refer to loading, and the timing of loading does not seem to affect at some point. Can you say anything about the timing of implant placement and the effect of either biological outcome or aesthetics? Or is that the message of tonight, that at this point, based on the work on this consensus conference, there's nothing we can say yet?
I think we should not take a message that you can do whatever you like. I think I was very clear that is delayed placement is the key word here, and the timing of implant loading doesn't place, but delay placement is important. Exactly. I think it needs to be a key message. I think then the second key message in terms of aesthetics is that, at least for the short midterm, is that if you have an implant, a single crown, a single implant, and you load it and you put a temporary, then overall this will not affect negatively the aesthetic outcomes. I think this is also a clear and safe clinical message. We can potentially say that if you do a delayed placement and you do an immediate temporary or a delayed restoration, that will not have any tremendous difference. But again, I think here we still need to have more clear data on that.
Mm-hmm. And
but I have to say also, this is the dental component. We need to look at the patient's component. The patients may like it just at the beginning, but at the end, once they get the teeth, it doesn't really play a role. So we need to see, are we actually serving our patients, or are we actually serving ourselves as dentists? But of course, that's a philosophical discussion, which is probably not the forum to discuss here.
Exactly. Hey, and Asbjørn, both of you looked at the PROMs, right? Out of the 4 articles that you both discussed, they looked at the patient-reported outcome measures. And both of you make a comment about how they should play a role in future research. Can you elaborate a little bit on that?
Well, both the PROMs and PREMs, patient-reported experiences, are very, very important. For those who have tried to recruit patients to be involved in trials, realize that patients, they want the implants, and sure they would like it for free, but basically a lot of these patients, they want to have as little invasive surgery in their mouth as possible. So minimal surgery, minimal invasiveness is really the key for in many fields within implant dentistry. And I believe also that that's where it's sort of alluded to, that immediate placement, immediate loading, et cetera, you cut down the number of surgical appointments, which is something some patients, I'm not saying everyone, but some patients appreciate very much. So I think that's also an element. And I think there's not enough emphasis on proms and prems in the literature, but that I think it's rapidly picking up because it's not only in dentistry, it's all fields of biomedicine.
Mm-hmm. And Nikos, I heard you make a comment about how these should be included in research, right? Where you said some of them are just secondary in the study, and perhaps what can we learn from that?
I think that a lot of this, and one of the important points of this consensus was that a lot of the outcomes that we consider important, like the aesthetics, for example, is very often a secondary outcome in most of the studies, which means that very often these studies are not powered, meaning the statistical significance that comes in is not necessarily reflected on the design of the study. And then that's the same with the proms. Some studies had, some RCTs did have proms as primary outcome, but many did not. So all of a sudden you come with these conclusions that this is better immediate or delayed is better or whatever, but actually the way that you design the study does not allow you to come with this specific conclusion in terms of the numbers of patients you recruit. I would tend to agree with Asbjørn that we need to listen to what the patients want in terms of how we modify our surgical techniques. And going to the first point of Irina, I think the new digital workflows will actually facilitate to integrate different procedures to allow the patients to have higher satisfaction and experience during implant rehabilitation. I think we dentists want to have faster surfaces, faster disintegration, which of course is related to the biological outcomes. But if we look at the overall implant dentistry today, the digital workflows, all these things that we discussed, it has to be related to how the patients experience that. Implant dentistry today, we can say, listen, when you have a 96, 98, 97% survival, it is a predictable treatment. We cannot deny it, and that's why we're here and discussing. So we need now to make it in a way that we serve the interest of the patient the best way possible. So let's use the technology to minimize procedures, to make them faster, but not more risky, because very often when you add risk steps, then you make too many miracles at one time impossible. So I think it's something this needs to be reflected how the patients feel when they actually know the risk associated with the different surgical procedures.
Mm-hmm. Final topic that I'd like to address in the last quarter of our EAO Just Ask on the Consensus Conference, that's a little bit more on the meta level, right? Because we've been looking for clinical tips and clinical recommendations, and we definitely heard a few very specific ones. But you have also been both extensively, not only in this Consensus Conference, in the academic side of the field, bringing science forward, as EAO says. Do you have some reflections either to clinicians trying to go through all the scientific work that comes out, or perhaps to fellow academics that are working and setting up studies that we can learn from you after all this work and all these studies you've been through?
Asbjørn, or so you?
Nikos, you go first.
I think that if we look at where EAO started or other organizations that did systematic reviews in their respective fields, you started from the basics, and you see as for every consensus conference at the EAO and other organizations, you see that the quality of research is improving. I think it's an achievement of the EAO that actually addressed the problems from the very beginning, and now every time we have more quality level studies. I think the fact that we start now, we need to insist on having RCTs in centers of excellence. We need to ensure that PROMS becomes an important point of evaluating a technique, surgical or restorative technique. And of course, I think the next step for us is we as a community to start collaborating in pragmatic trials, field trials, where basically it is one story that a product will work very well, maybe in a very strict university clinical research environment. Another story that it will be applicable on a field study where basically the specialist or the general dentist with a special interest will actually apply these procedures. So I think we need to start seeing more RCTs when we evaluate a specific efficacy, but also we need to start moving to the effectiveness and start having some pragmatic trials, field studies, as they call them in the industry, to see how the different protocols operate, always with the patient in mind as well. So the power of these studies has to be adequate for the primary outcome, and sometimes the primary outcome should be also the patient-reported outcomes. That's how I view things following in the next few years for the future EAO consensus conferences.
Yeah, and very clear recommendations, Nikos, about the randomized controlled trials in centers of excellence, focus, you say, and then always keep the patient-related outcome measures also at the center of your work site besides the primary outcomes. Very hands-on advice for the academic side of our viewership. Asbjørn, if you look at that, any advice for clinicians seeding through all the papers that come out? Now that we have the global internet, we have a global audience, how do we distinguish sense from nonsense?
That's the daily challenge that we all face. 20 years ago, some colleagues and I, we wrote the papers, something called The Quality of RCTs in Implant Dentistry. I think we covered maybe 60 RCTs. My latest count in my own database now is 1,800. It's just exponential. There's no way that you can pick all that up. And perhaps also the infuriating situation for clinicians is that the randomized controlled trials is basically a very simplistic study design. It gives you the answer to one particular question: is A better than B? Period. So we can go around and compare A versus B and B versus C and C versus D. And in the end, if you have 200 of those, you may get an impression of what is better than not. But is that really the type of science that the clinicians need? Clinicians, they need pragmatic studies, which needs multi designs, not limited to retrospective or prospective. I think there's a few practice-based research networks going on, some very good one in Germany I'm aware of. More and more countries are putting these up, where clinicians with the tools of digital tools, online tools, can actually merge their own clinical data to set up databases. I think that is really a very exciting avenue that more clinicians worldwide should really sort of join, because getting large numbers, I think, is more relevant than perhaps 20, 40, 60 odd restoration done by super clinicians on select patients in super staffed hospitals. It shows us the potential results that can be gained under perfect conditions, but it doesn't necessarily reflect real-life dentistry. So I'm a strong in favor of practice-based research network when it comes to really to where do we go from now. But can I use the opportunity to add one item I forgot?
In a minute, Asbjørn, hold that thought, because we actually have a very live, very practical question, and that's something we want to celebrate, of course. Lucas Wa is saying, wait a second, if I have these two renowned professors here talking about study setups, let me ask them a very practical question. Lucas is writing, I'm planning an RCT with immediate restoration with PROMs as a primary outcome. How would you advise on calculating a sufficient sample size with so little data as a basis in literature? Thank you. It doesn't get more hands-on than this.
Well, the beauty, it depends, of course, the specific circumstance. The beauty of these systematic reviews and the meta-analysis is actually they will give you the mean and the standard deviation in specific clinical situations to be able to analyze, to make the power calculation. So the Gottfredson paper actually provides you these numbers that for you to be able to calculate a specific RCT, I assume it's immediate placement or immediate loading or combination with proms. I think the interesting part that you need to see is which proms you're going to use as well, because depending on which proms you're going to use, you may or may not have different means and standard deviations. But I certainly, this EAO consensus really moved things forward in terms of evaluating the proms. And the paper from Group 1 and the paper from Group 4, I think, is able to provide to the researchers the first steps to be able to calculate at least an RCT. I would like to just add on what Asbjørn said. I think my point is that we still need RCTs for efficacy of products and procedures, but effectiveness is the key. And effectiveness is bringing the community together. And actually, we are now looking at, we need to have standardized protocols between different countries. We need to create data warehouses where basically we're able to see how the clinical procedures operate over the years. And I really think that if you look at where medicine is moving, data warehouses, artificial intelligence created by data warehouses is where things are moving in medicine big time. And I think this is where we're going to be evaluating ourselves in a few years from now. But coming to our
Nikos,
colleague, I think
when you say this, who should take the lead in this? Is this the universities? Is this a body like the EAO? Is this who should start to gather this work into this database?
Well, certainly there's EAO. They are leading clinical academics and leading clinicians who they can create teams, and of course creating protocols which are internationally scrutinized and internationally applied. The problem here is usually the funding in these situations. But again, we need to utilize the fundings that exist in different countries to support this kind of multi-center pragmatic trials. So the lead is usually is leading university centers, but in collaboration with clinicians who are able to have numbers of patients. As Asbjørn probably would agree with me that one of the problems that we face in pragmatic trials is that I might place 5 implants and Asbjørn might place 1,000 implants. So immediately we have the center effect, which is creates some kind of bias or some kind of negative outcome. So again, you need the clinicians with the numbers and the experience, which is in the field that they place, and they create this kind of that they support this kind of studies.
Cool. Thank you. Good message. Asbjørn, you said I forgot one thing. Please add in our last few minutes of this session.
Yes, the new avenues in computer-assisted manufacturing opens up for enormous creativity when it comes to new materials, both ceramics and composites, and combinations of ceramic and composites. It's a, I shouldn't call it rat race, but it's like a battle for the market. Now, when it comes to the term monolithic zirconia is not the same as monolithic zirconia. So don't just believe any slogan saying, oh, this is monolithic zirconia, because that may be something like 8 different types of zirconia. Because zirconia today is being made with different processes, some because they want them to be translucent, and some because they want them to be strong. And some market this as both translucent and very strong, which is not possible, or alternatively. So be very specific when you consider monolithic zirconia materials, in that you really get what you're asking for. So apologies for forgetting that.
No, it's an important point, right?
And as I showed some minutes ago, when a huge company like 3M SB can put on the market a product that doesn't work, that the manufacturer is really well known and respected is not necessarily a safeguard against a product that shouldn't be put on the market. So these things happen. So yes, sorry for the bad news.
You're saying be cautious. Don't believe everything you read, both as a clinician, but also as your big call to action for both of you as a scientist. Stick to the reporting guidelines, make your papers available for the large databases so we can actually build and work together. With that, looking at the clock, I'm gonna, before I have some final household messages, thank our audience for your active participation. I mean, there wasn't hundreds of questions, gentlemen, but there was a lot of likes, a lot of sharing. So I guess a lot of people were happy with listening to you both. And if you have been watching this and you know someone who wasn't with us live tonight, be aware that this link is an immediate replay once we stop. So you can share it with anybody who might be interested to that as well. Nikos Donos, Asbjorn Jokstad, any final call to action or word from your side before we close tonight? Nikos.
I think that we covered a lot today, and I wouldn't necessarily like to tire the audience, but certainly we found out a lot, but we need to investigate more. And I think we need to ensure that the next step for us will be RCTs, systematic reviews, clinical guidelines based on RCTs, and field studies. I think this is what I would like to be seeing the field moving on.
Nice. Thank you so much for sharing your insights tonight and this very to-the-point comments that you made. Asbjorn, what would you like to highlight?
And I should like to add that not necessarily with the message that don't believe everything you hear or read. It's more like be open to everything that is coming now, because there's so much enormous information out there. And there's also always value, whatever study methodology, however badly written a paper is, there's always an element of knowledge in there that you may benefit by reading it as a clinician. But again, learning how to differentiate between excellent research, good research, not so good research, that takes a long time. And that's not the topic of this evening's lecture.
Exactly. But we're glad we have you and all the 70 experts that contributed to the consensus conference to actually see through all that work and tell us what at least the consensus of this year's is. And hopefully in 2-3 years' time, we have another one and we keep track of that. For those of you who are interested, please save the date, because we will be back with more EAO Just Ask sessions next year again. It's Monday night. It's on the EAO channel here on YouTube. And the first one coming up is on January 17th, where we have our second special edition on the consensus conference. Then we talk about the work of Group 2 on soft tissue management and Group 3 on peri-implantitis. So I hope to see you back on that session as well. And if you can't get enough of all this great scientific insights and content, make sure you check out all the other videos on the EAO channel here on YouTube. Hit the subscribe button so you'll be the first to know when a new live session or a new video is published. And with that, I'd like to one more time ask you for a big virtual applause for our experts here tonight. Asbjørn Jokstad, all the way from Norway, and Nikos Donos from the UK. Thank you for your hard work and sharing your insights. See you next time.